Good afternoon, our honorable speakers and dear attendees. So welcome back to the second webinars of 2026, hosted by WHO country of Myanmar. So I am Dr. Situ Sui, National Professional Officer for NRMNCH team. It is my honor to be a moderator for today's section. So as you are aware, today our focus is on sharing the WHO updates on Kangaroo Mother Care practice in country experiences. So this webinar is catered to a diverse audience, including the public health policymakers, implementers, maternal and child health program manager, professional association, NGOs, health professionals such as doctor, nurses, midwife, and all. So for today, we will have three main agenda by our distinguished speakers. So the first session will be KMC clinical practice guides in parent counseling guides. So second will be the sharing the country experiences on the implementing community-based KMC. And the last will be the KMC for the baby in special care units in neonatal intensive care units. Before going for the presentations, we would like to play a video clip for the KMC created by WHO. So please enjoy the video with us.
Globally, 1 in 10 babies are born too soon, before 37 weeks of pregnancy. Many more have a low birth weight, under 2.5 kilos. Survival is poor. Complications from prematurity are now the leading cause of child death worldwide. But new, high-quality evidence shows that a simple technique has the power to save the lives of hundreds of thousands of these babies every year. Kangaroo Mother Care includes continuous skin-to-skin contact between a mother and a baby, held securely in a sling or wrap for as many hours in a day as possible, and exclusive breastfeeding. WHO recommends Kangaroo Mother Care as the essential standard of care for all preterm or small babies, both well and sick, starting immediately after birth. It has been shown to save lives, reducing infections and hypothermia, and improving feeding. It provides immense benefits compared with the common current practice, whereby small or preterm newborns that require specialized medical care are separated from their mothers and caregivers inside a newborn care unit. So here is how you can help ensure every small and preterm baby gets the skin-to-skin contact they need from the moment they are born. Mothers can provide Kangaroo Mother Care for their babies starting immediately after birth. Fathers, partners and family members can provide help and relief, stepping in when mom needs rest. Facilities and health workers can help ensure mother and baby stay together right after birth, even when the baby is sick. For many facilities, this will require a radical shift in the way care is provided, so that mother and baby receive medical care together in one place, even if the baby is sick and needs intensive care. Governments should recognize and fund Kangaroo Mother Care as essential for all preterm or small babies. Kangaroo Mother Care can revolutionize how we look after small and preterm babies. Let's make sure every baby gets the contact they need together from the moment of birth.
Thank you. Thank you. I hope you enjoy the video, and I believe you will have more visibility on the Kangaroo Mother Care, how is it look like, and how it can benefit to the mother and babies. So Dear Dandy, so now we are going for the main agendas of the today's section. So before inviting our honorable speakers, Dr. Rajesh Khanna, so I would like to introduce you a brief biography. So Dr. Khanna is the medical officer for newborn and child adolescent health at the WHO Regional Office, Southeast Asia region in New Delhi. So in this role, he worked closely with the member states and partners to provide thematic leadership and technical support in developing national policies. So his work is dedicated to ensuring equitable and universal access to the quality healthcare to improve the life of newborn children, adolescents across the regions. So Dr. Khanna is a medical doctor trained in pediatrics and public health with over 25 years of experience. So before he joining WHO, he led the multidisciplinary teams at the community, national, and global level, including the prestigious institutions such as NICE in the UK and in Save the Children in India. So he has co-authored and contributed more than 50 research articles and global policy documents for the government of India, NICE, and also with WHO. So please join in welcoming Dr. Rajesh. So the floor is yours.
Thank you, Sidhu. Very good afternoon to all of you, and thank you for inviting me here. I think this is a fantastic platform, and the intervention that we are going to talk today is very much relevant for country like Myanmar, because this is one of the most cost-effective intervention that you can ever find to take care of the small and sick newborn. Sidhu, can I have the presentation, please?
Yes. Next, please.
Yes. Next, please. Okay. So I was asked to speak on two areas, the clinical practice guide and the parent counseling guide. But considering the time and knowing that we are going to be together with a group of practitioners, so I have tried to focus only on the clinical practice guide. But at the end, I will be showing you the list of resources that are available, and you can go and study them at your own time whenever you have. Next slide, please. So I'm going to start with a little bit of understanding on how did KMC evolve, what's the new evidence, what are the key principles and benefits, which most of you will be aware. And thankfully, the starting video that was played has given a lot of background information, so it will make my task easier. Coming to the history of KMC, specifically the WHO guidances, how they have evolved. Then we will come to the clinical practice guide, understanding why this guide was needed, how it is structured, what are the key updates, and then coming to some basic questions. Who should receive KMC? Who should deliver KMC? Who can provide and where it can be given? Then specifically, at the health facility level, what are the specific requirements that are required in order to ensure KMC is implemented effectively? And then how services can be provided in KMC. And last but not the least, but one of the most critical elements, how do you support mothers, families to practice KMC at home? Fortunately, I will not be focusing on two important topics which will be taken by my esteemed speakers. One will be on community KMC. You will hear Professor Shashi, who will be speaking on community-based KMC, and then Dr. Harish Chellani on how do you initiate KMC in small sick newborn care units in level 2 and 3 units. Next slide, please. Next. So probably KMC was started way back in 1978-79 by two pediatricians, Dr. Ray and Dr. Martinez in Colombo. And they started it because they were having resource constraints. There was overloading of the hospitals, and in order to save resources and prevent infections, so they started this practice of Kangaroo Mother Care. So this was how the term. We also know that the WHO had this recommendation that in stable babies, KMC helped to improve survival by 40%. And this was going on for quite some time. But when we reviewed it in 2015, what we realized was that despite having credible evidence, the coverage of kangaroo mother care was less than 5% at the population level. Secondly, one another big gap was that KMC could only be initiated in hospitals, though we knew that at the community there were practices and it was quite safe to do it, and it was much more effective for for low birth weight babies. And the third, before KM, well, because the recommendation said that you have to start KMC only in stable babies, most of the deaths used to happen before stabilization could happen. This is the time when WHO, next slide please, when WHO coordinated a multi-country research on three key areas. One, how do you scale KMC? Second, is it possible to initiate KMC in the community, at homes, and whether that's safe, effective? And third, is immediate KMC compared to the conventional care? What benefit do we have, especially in terms of reduction in mortality? And then there were some other outcomes, which again, I think Dr. Chellani will be referring to. But it was mainly looking into mortality reduction and then morbidity and other long-term effects. So these three studies were initiated. And if you look into the outcome, what we saw was from 5% KMC, when this implementation research was conducted in two countries, nearly 10 times, 10 to 16 times increase in coverage was as an outcome we could see. Community initiated KMC, main thing, 30% reduction in the mortality as compared to those babies who do not receive KMC. And then immediate KMC. Now, interesting thing about immediate KMC was that this was started also in sick newborns. And that was responsible for nearly 25% mortality reduction. This was done across 5 countries. Next slide, please. So in the video, you saw 400,000 lives saved. And this was based on the results of these 3 studies, and then further when you model them at the population level. If KMC continues at the level which was there in 2015, you could hardly say save 10,000 babies. When you scale it up, but only in stable babies, then 15 times more lives you could save. It increased from 10,000 to 150,000. When you add community-based KMC also, 250,000. So 25 times increase. The best was when you add immediate KMC and you include sick babies, sick preterms and low birth weights. The impact increased many folds. And that's why you have this figure of 400,000. Next slide, please. Based on this new evidence, when WHO developed the new guidance on the care of preterm and low birth weight infant, so KMC came up prominently, and specific recommendations were based on the strong evidence that was created. First, recommended as routine care for all preterm and LBW infants, but 2 important points within it. It can be initiated both at health and at home, and should be given for 8 to 24 hours per day. Minimum 8 hours was the recommendation. Second, it should be started as soon as possible after birth, irrespective whether the baby is stable or requires medical care. There are few indications which I will discuss later on when it cannot be started. Third important component, family involvement with mother as the central figure. And fourth, home visits to support mother and the family if it's being carried at home, KMC. Next slide, please. So these are the key principles. We have already discussed this. I'll just focus on 2. Kindly note that when we talk of kangaroo mother care, it's different from skin to skin contact. It is a prolonged skin to skin contact, minimum 8 hours, preferably all 24 hours, depending on how much mother is able to do. And it has to be supported with exclusive breast milk or breast milk feeding. You don't call only skin to skin contact as KMC. That's going to be very important moving forward. Second, idea principle should be that the mother and infant should stay together at all times. Third, very important point, immediate KMC. Normally, the practice is that whenever a baby, preterm or a low birth weight baby is, and we put them either in the radiant formers or we put them in the incubators. Incubators is the old practice, but still many countries continue to do. Immediate KMC is the best option standard of care. It should not be considered as if it's only to be done in low resource. In fact, it is one of the most cost effective and highly specialized care which you are trying to give to the baby in terms of its short and long term outcomes. And last, it requires actions across all levels of health systems, cannot be limited only to tertiary care levels. Next slide, please. Benefits, I will skip because we all know that it's immediate, long-term benefits, benefits for health workers. More importantly, which we don't understand is how much important it is for the mothers, families, and fathers. Maternal bonding, which is one of the, I would say, moving more than maternal bonding is also the family bonding that you will see in the pictures, how it leads to that, how it promotes respectful care. And we often think that if we get mother and newborn together, it will be an additional burden on the health system. But the results have shown that it's vice versa. It leads to reduction in the healthcare cost compared with the conventional newborn care systems. Next slide, please. So this is how the KMC, first we had the practice guide in 2003. Then when 2015 onwards, we had the WHO guidance in 2022. Following this, in 2023, we had, based on the evidence, we had two WHO publications. One was the global position paper, which brought it out that this has to brought it because we needed a shift in the mindset of the healthcare professionals, and also to show that this is not a low cost option. This is the best available option and it should be the standard of care across all levels of healthcare. And then came out with an implementation strategy. Next slide, please. Next slide. Yeah. Then brings us to the question, when we had the evidence, then why are we talking of the practice guide? This became important. Then the last practice guide was in 2003. Now with the new evolving evidence, also because of the fact that we were talking of immediate KMC, and especially when the small and sick newborns we are talking of who require treatment in either level 2 or level 3 facilities, how do you provide them kangaroo mother care? There was no operational guidance, so this practice guide is predominantly was developed with these following aims. Next slide, please. This is an overview. The practice guide is divided into 5 chapters, starting with an introduction, understanding KMC, why is it important, who requires, who needs it, who can give it, and how long it should be given. Then what are the essential requirements in chapter 3 at the health facilities? Then when you give the services, what are the mechanisms that you need to cover for service provision? And then how do you support families, mothers, and the fathers to practice KMC at home in the community? Next slide, please. These are the terminologies which was specifically taken that when this practice guideline was, that there are some standard terminologies that were used. First, the KMC sued after birth is irrespective of the place. You can start it at labor rooms, OTs, and the idea is it has to be prolonged. So there has to be continuity when it given at home. Kangaroo position was used in the previous. Also, sometimes we use frog-like position or fetal position. That has terminologies have been removed because fetal positions generally bring some degree of flexion, which is not compatible with KMC. Then the third was KMC, again reinforcing it's not just skin to skin contact, it's prolonged skin to skin contact with breast milk feeding. And lastly, discharge and follow-up criteria, no specific criteria was given. Now, this is important to note because WHO guidance is for all the countries, and every country will they have their own levels of health systems and capacities and capabilities at different levels. So this is something that the countries will have to decide how do they want to do it. Next slide, please. This we already said, but most importantly, this is who should receive KMC when it comes to the question that it should be for all preterm and LBW newborns. Only one contraindication is if they are hemodynamically unstable or are unable to breathe spontaneously. It means that maybe they have been ventilated. But if the baby is on CPAP or is sick but is requiring continuous medical monitoring but is hemodynamically stable, you can give it. One big contraindication is only when it is not feasible to do it. Suppose there's a major congenital malformation. In that scenario is the only one where you can avoid KMC. Otherwise, there is no contraindication to any preterm or LBW baby receiving KMC. Next. The second is who can provide KMC. The primary caregiver should be the mother, but we also know that the mother has also gone through the process of delivery. So she also needs some rest. And maybe when the mother is sick, when the mother herself is unable to deliver KMC, she might be having convulsions, she might be having some mental illness. In that scenarios, we need additional caregiver. And these two photographs you can see on the right side is the mother-in-law, left side, sorry, is the mother-in-law, and on the right side is the father giving KMC. Next slide, please. Now, as I said in the beginning that KMC should be provided at all levels. So the three levels. First is the primary level, where we say it's the essential newborn care. The KMC can be initiated either in the labor room or in the operation theaters, depending on the mode of delivery. If mother is sick, then you say you don't start KMC, then because it's an additional caregiver who's giving, you say you start skin to skin contact. Next, at the secondary level, all preterm and LBWs again can be started on KMC unless a high level of care, which I said in the beginning. Just previously, I said if they are hemodynamically unstable or there are major congenital malformations, that's the only contraindication. Now, interestingly, at level 2, where we call the special newborn care units, it's usually where babies have some breathing difficulty. They might be having respiratory distress, cyanosis, they may be having convulsions. In those scenarios, when the baby is hemodynamically stable, you can initiate KMC. This can be done in the traditional newborn care units or in the maternal newborn care units. Now, maternal newborn care units is a new terminology that you are hearing. Again, Dr. Harish will be telling you more about it, but it's predominantly a place where mothers and newborns are made to stay together 24/7. The whole infrastructure changes and enabling environment is created for both the mother and newborn diet to stay together all the time. Next slide, please. And level 3, similar to what we saw in level 2, you can continue to give for sick newborns, preterms and LBW babies KMC 28, more than 8 hours, this Kangaroo Mother Care can be given. Next slide, please. This comes to the next question, how long KMC should be continued? There is no definite, it's for the baby to decide how long. And the baby will tell you, once the baby is able, when the baby decides that it's able to maintain its own temperature, then the babies will try to wriggle out of the KMC position. And that usually happens when the weight is around 2.5 kg or the baby is about 38 weeks to 40 weeks of corrected age. Next slide, please. Next. Now, when you talk of the health facility requirements, these are 7 core things that you should take into consideration. It talks about policies, protocols, infra, equipment supplies, health facility records, workforce, service delivery, cost of delivery. So we are talking of all the components of health systems. And this should be made available at all the 3 levels, the primary, secondary, and the tertiary. There can be some adjustment based on your country's needs and resource availability. Next slide, please. Policies. At what we need is enabling policies at the facility level to allow the mother and newborn to be kept together 24/7. Very important to have records. Normally, when we record KMC, we miss certain key components. These are the essential elements that should be essential data elements which should be kept: gestational age, birth weight, KMC starting time and duration, frequency of exclusive breastfeeding. All these are key components because tomorrow we will have to monitor how the facility is doing. And if we don't record these things, it becomes difficult. Workforce is again going to be a critical essential. Initially, when the concept started, it was always thought that training the health workforce, they find it difficult because you are training a mother also. But over a period of time, it becomes much more easier for the nurses and the healthcare staff to realize that KMC reduces the burden of their work. And last, the cost of care. There has to be, whenever any health facility wants to start KMC, there has to be a dedicated budget. Not only to make sure that you start, but also for the maintenance of the cost. And all the details are given in the clinical guide. Next slide, please. I'll just be going through the infrastructure. Now, for infrastructure, there has to be a provision to provide KMC at all levels, at all the places where you can see mother and the newborn. Wherever first in the delivery rooms or the childbirth areas, there has to be a dedicated space for mother and the additional caregiver. And the same goes for secondary and tertiary level. It is across all 3 levels. Where newborn care areas, where newborns are taken care of, maybe either in the postnatal ward or in the intensive care units or the special newborn care units, there have to be dedicated KMC areas. The only thing we have to take is that there has to be some privacy and adequate space and enabling space as per the 7 criteria that we have already mentioned in the previous slide. Next slide, please. One important thing, can you go to the previous slide, Sidhu? Sorry. Yeah. One important thing is the supportive environment. I think it's very important to ensure that there is provision for clean water, toilet, mother to shower, hand wash area, her place for eating. Because if you are expecting mother to stay with the baby 24/7, these provisions will have to be made. Otherwise, the mother will not be able to take care of the baby and she will herself feel suffocated in the environment. Next slide, please. Just showing you a few photographs. This is the labor room. Next slide. On the left side is the traditional special newborn care unit at the level 2. How KMC is being provided by the On left side, you can see a mother and then by fathers. And on the right side is level 3 unit, how KMC is being provided. Next slide. And this is a postnatal care ward, an exclusive ward, which is known as the KMC ward. The idea is when KMCs, in order to ensure privacy and the mothers feel comfortable, a separate ward for mothers to provide KMC during the postnatal period. Next slide. Another important requirement is the equipments and the supplies. The beds, garments, wheelchair, equipments, these are all essential and they are not costly, but they are very essential. Next. And these requirements are going to be in addition to what level of care, according to the level of care, the services are being provided. These are the different type of chairs, but the main idea behind getting any chair is that it should have adequate back and leg support, and it should allow mothers, because we are asking the mother to hold the baby on the chest. She should have comfort in doing that for an extended period, minimum 8 hours. So the chair has to be comfortable. Next slide. Another important aspect is the binder. There are different type of binders. You can use the locally made binders. You can use some binders can be customized. Then there is elastic fiber fabric, which helps to make a tube type binders. The main idea behind any binder should be that it should be able to securely position newborn between the breast of the mother. The head and neck should be maintained in slight extension, and the baby should be supported. So it should be, the support should be so strong that when the mother is standing, the baby should not slip out of the binder. Next slide. And then above it, sometimes in order to reinforce the support for the baby, a KMC garment is worn over a cloth binder. It is also for mother to feel much more comfortable when she's surrounded by people outside to maintain her privacy. Next slide. Next. Yeah. So when we are coming to the KMC in health facilities, these are the different aspects. I'm not going to go into details. I'm just going to show you how this is, because if you go into the depth, it will take more than 1 hour, and I have to be respectful to the other speakers. So these are the different areas that are covered, what you need to do for counseling during the antenatal, because counseling has to start from the antenatal period. How do you start KMC in birthing areas? How do you continue in the health facilities? What are the things that you should be doing? How do you monitor the practice? And then at the time of discharge, what you should do. Next slide. Feeding is going to be very important. As KMC, two important points: prolonged skin to skin and breastfeeding. Either it should be direct breastfeeding, or you can continue breastfeeding through a spoon or through a cup. That has to be there. Also, in case the baby is unable to take it you can give express breast milk through the NG tubes. So this is a chart which tells you when to start direct breastfeeding, but if the baby is not able to take it by spoon, if it's not able to suck directly, then you can give it by spoon or cup. And then in case that is also not acceptable, or the baby is very small, is not able to suckle, usually happens when the baby is extremely preterm, less than 32 weeks, then you start with using NG tubes, but supported through non-nutritive sucking. Next slide. I will just play one video and that will be the end. After this is a session on how do you support parents. Now there are 16 videos along with this guidance, and I would suggest please watch these videos very carefully. I'm just going to play one video and after that I'll stop. So Situ, can you play? This is how do you place a stable newborn in the KMC position. These have been globally developed and these are of excellent quality. So Situ, over to you. Please play this video.
In this video, we will demonstrate how to safely position a small, stable baby in skin-to-skin contact with the mother for Kangaroo Mother Care or KMC. A baby is considered stable if they have normal vital signs, heart rate, respiratory rate, and temperature, are breathing independently without respiratory support, and do not require specialized monitoring or care. Start by performing hand hygiene and checking the baby's vitals. Dress the baby in a cap, diaper, and socks, leaving the rest of the body bare for optimal skin-to-skin contact. Ensure all medical devices, such as a pulse oximeter, intravenous line, or feeding tube, are securely positioned. Position the mother comfortably in a reclined chair or on a bed at a 30 to 40 degrees angle. She should wear a loose, front-opening garment suitable for the local culture, with a binder or wrap if needed to secure the baby. A binder can be a long piece of cloth that ties securely, or a tube-top style that slips over the baby. The mother should put on the binder beneath her garment before positioning the baby. Gently place the baby on the mother's chest, between her breasts, in a vertical, prone position. Ensure the head is turned to one side with the neck slightly extended for an open airway. The baby's arms, hips, and knees should be flexed, with hips slightly abducted, allowing the baby to bring their hands to their mouth. The position should also enable the mother to kiss the baby's head. Guide the mother to support the baby's neck with one hand and the bottom with the other. Once she has a firm and secure hold, carefully remove your hands. Tie the binder so it reaches just below the baby's ears and supports the bottom. Secure it with a simple knot on the side, making it easy for the mother to adjust. If using a tube-top binder, gently slip it over the baby to keep them securely in position. The binder should be snug enough to keep the baby secure, but not tight enough to constrict the abdomen. For added support, the outer garment can be tied below the baby's bottom. Each KMC session should last at least an hour, ideally longer. If the baby is stable, encourage the mother to move while ensuring a secure hold. Healthcare workers will monitor the baby, but the mother should also observe color, breathing, and activity, reporting any danger signs promptly. Twins or triplets can be placed in the KMC position with a single caregiver, with one baby on each side of the mother's chest. A longer binder can be used to secure both babies safely. After positioning the baby, ensure proper alignment, intravenous fluid flow, and pulse oximeter readings while monitoring the baby's condition. Stay with the mother until she feels confident in providing KMC. Teach her how to breastfeed and change diapers in this position. Proper preparation is key to successful KMC, so take the time to do it right.
Yeah, thank you, Sidhu. You can clearly see, the contentment and the happiness of the face of the mothers. The anxiety that normally every child, every family has when they have a preterm or a low birth weight baby. How it gets done. Just can you go to the last slide, please, Sidhu? Yes, next. Yeah. So these are the three key elements. What things can you do, and the policies at the community level, what components community health worker can support, and then for home monitoring and records, what needs to be done. And on the right side, the photographs clearly you can see changed role of fathers, father cooking with mother taking care of KMC, and mother providing KMC with the entire family support. So in the end, what we are seeing is an increased bonding. Next slide, please. So thank you very much. And these are the list of resources, WHO resources. It will be shared by the Myanmar team after this. And the links to all these resources are given in this last slide. So thank you so much. Stop now. Any question, happy to answer.
Yes. Thank you, sir. Thank you, Dr. Khanna, for your presentation. We have learned a lot on the recent update recommendations and the practice from the WHO on the KMC, Kangaroo Mother Care practice. Thank you, sir. So dear attendees, so if you have any questions or comments, please feel free to put it in the Q&A box. We will pick at the end or during the next presentation, our speaker will address as relevant. So now we are going for the next important section in which our honorable speaker, so Professor Shashi N.Vani, so will share about the experience on the community-based KMC. So before inviting Professor Shashi, I would like to briefly introduce her. Professor Shashi N.Vani is now currently as is the Emeritus Professor of the Paediatrics, including Neonatology of the PS Medical College in India. So she simultaneously holding the position of the president and the managing trustees of the KMC Foundation in India. So previously, Professor Vani was the senior professor and head of Department of Pediatrics, including Neonatology at the Paediatrics Medical College in India. Her leadership experience includes serving as the coordinators of the Asia Oceania Network or KMC for 3 years. With a total of 60 years of the clinical, academic, and research experience, Professor acts as a technical expert and member of Neonatology and China Committee at the central and state level in the Ministry of Health and Family Welfare in ICMR. So her career is marked by the Lifetime Achievement Awards from the Indian Academies of Pediatrics and many others. So with great thanks for agreeing to support us for today's webinar, so I would like to invite Professor Shashi N.Vani to kindly do the presentations. Mans, the floor is yours now.
Thank you very much for the kind introduction, and very happy to have this topic for discussion today. Dr. Rajesh has made my task much simpler by putting a solid background of foundation of Kangaroo Mother Care. Now today I'll be speaking on the community-based Kangaroo Mother Care, vaguely with the respect from our country experience. Next slide, please. I bring greetings from our KMC Foundation of India. Next slide, please. And we have been working for the promotion of Kangaroo Mother Care for past several decades in India, particularly in last 1 decade. And our mission is to spread the concept that mother's chest is the best place for the newborn care, mother's milk is the best food for the newborn, and zero separation of mother and her baby. That is one of the best principles of newborn care. And these 3 mission statements we developed long before they were supported by WHO recently. And our another vision is KMC should be a part of the routine care of the newborns, not only for the preterm and low birth weight babies, but for all the newborns. Of course, there are special benefits for low birth weight infants, including the preterm babies, but all the newborns also have some benefits from Kangaroo Mother Care, which are very important. And it is not to be considered something different or special. It should be woven as a part of the routine newborn care. So that is our vision. And we are really glad that over the years, gradually we are progressing towards achieving our vision. Next, please. Our main thrust for the newborn care currently is not mere survival. Because earlier, with the help of all the equipment and all the other gadgets, our aim was to somehow survive the newborns particularly highly vulnerable preterm and low birth weight babies. But now, not mere survival, but for an overall well-being and thriving with good intelligence, love, and good quality of life for the long term. That is our aim. Next. And to achieve that, Kangaroo Mother Care appears to be one of the best interventions, and gradually it is proving to be a game changer for newborn care in India. In all the situations, now we are trying to promote Kangaroo Mother Care. A few exceptions, Dr. Rajesh has already mentioned. Next. We already know that it is a humane and low-cost evidence-based impact, but the uptake is low. Next. I'm not going to repeat some of the things which are already told. But now our emphasis is more that it is an emotionally supportive care of the newborn and is a method of nurturing the newborn through a loving hug. KMC helps the newborn with better quality of life. Next. Because of the time limit, I'm just highlighting some of the important concepts, trying to not duplicate the same things which have been already told. So again, among so many benefits which the baby gets, mother, family, community, and the facilities and country gets, the emphasis is mainly that it lays a sound foundation for early child development, better nurture and well-being. And it also helps for the mental health of the mother and the family also. Next, please. In India, we are facing one of the most difficult challenges of the newborn health. We have got the highest number of births, 26 to 27 millions, and there, two equally important components we have to recognize. Facility-based newborn care is very important, but equally or even much more important component is community-based newborn care also. And now there is a lot of efforts to promote community-based newborn care, and in that also KMC plays a very vital role. Next, please. And they have realized that a quarter of newborn deaths can be averted by universalizing the kangaroo care. That is, a few babies with good quality of kangaroo mother care, only the individual babies will benefit. But overall benefits in the community can be seen only if minimum of 90% coverage is there. Next, please. So they have even the WHO series on and Lancet series on neonatal survival. They have highlighted that in developing countries like India, with very high neonatal mortality rates, combined with weak public health systems and inadequate facilities, simple interventions like breastfeeding promotion, kangaroo mother care, hand washing, and other things can save thousands of newborns from dying due to easily avoidable as well as treatable causes, provided at least 90% coverage is achieved. This was recommended in year 2005. Over the years, we have made some progress in all these components, but still we find that a lot of things need to be achieved. Next. So, in achieving wider coverage in countries like ours, promotion of community-based kangaroo mother care is urgently needed. Community-based kangaroo mother care is also otherwise described as home-based kangaroo mother care. In fact, both these terms are synonymously used in most of the situations. In the context of our country, home-based kangaroo mother care is relevant in three major groups. One group is where the baby is delivered in the hospital. KMC was started as required as per the guidelines laid down, and then the baby was also discharged as per the criteria laid down in the hospital, and early discharge is one of the important component of Kangaroo Mother Care, and this babies continued post-discharge home-based Kangaroo Mother Care till the baby decides to leave the Kangaroo Mother Care. This is the first ideal group. But second group, which is still the larger group in our country context, is hospital delivered newborn. KMC started in the hospital, but due to several reasons, parents could not stay in the hospital for the desired level of time, so they had to take random early discharge, and KMC had to be continued at home. Nowadays, with the government incentives, the incidence of institutional deliveries, hospital deliveries is increasing. But the incidence of desired level of hospital care is not achieved. So this group becomes a very important component for home-based Kangaroo Mother Care. And still there is a third group. With all the efforts in the government, we are having home deliveries or deliveries outside the facility. And due to several reasons, they could not be taken to the hospital in time, and Kangaroo Mother Care has to be given at home. So like that, we have got three groups: hospital delivered and hospital care babies, hospital delivery and inadequate care deliveries, and home delivered babies. And in all these situations, home-based Kangaroo Mother Care or community-based Kangaroo Mother Care has to be initiated for the benefits of newborn. And with our increasing experience, we have realized, sorry, KMC transport of the newborns in community, that also forms a part of the community newborn care. So, home-based Kangaroo Mother Care has to be included in the care of the babies. Next, please. Our government has also realized the importance, and they have developed now several more training modules and the volumes to increase the coverage and quality of Kangaroo Mother Care. Next, please. Sorry. Lots of efforts are being done to improve the facility-based Kangaroo Mother Care. Next. And lots of volumes have been produced to include all the components of Kangaroo Mother Care and family participatory care, emphasis on the lactation management, home-based care, and so on. And soon we have realized that in the component of home-based newborn care, we have to include home-based Kangaroo Mother Care. Next, please. Healthy Newborn Network has also recently realized that community-based KMC or home-based KMC has to be a part of the newborn care. And the basic principles of facility-based or home-based care remain the same. But depending on the community context, within the acceptable range of scientific evidence, a few alterations have to be made. So that is an important part we are learning. Next, please. Now, to support this concept, we have a number of background studies and experiences from India. Kangaroo Foundation of India, that was the first one to initiate community-based, home-based Kangaroo Mother Care way back in year 2003. These were started in situations where no other better alternatives for newborn care were available, and Kangaroo Mother Care was thought to be one of the interventions which may be useful. But after 10 years of solid experience, we realized that this is a very useful intervention. And in those days, there was an idea preventing that community newborn care, particularly introducing KMC in community, may not be very safe. There were one or two studies published also to the tune. But our experience gave us confidence to introduce community newborn care, and we studied it also systematically in year 2013 to 14, and we presented our findings in the 10th International KMC meeting in Kigali and also in Trieste. And everywhere they were well received, and the important observations was safety, feasibility, and acceptability of home-based KMC in India through trained community health workers who are trained for repeated scheduled home visits and what to do. So, a lot of emphasis was based on strengthening the community-based newborn care rather than solely relying only on the hospital settings. And this conference was pivotal also in advancing the integration of KMC into community health. Next, please. Based on our experience, we requested ICMR to take up another study, and this was published also. And this was a multicentric study done in urban settings, rural areas, and tribal belief. And they also endorsed the same findings that HBKMC is feasible, acceptable. And another important concept is at least no harm done. So that was very important. And some of the common barriers were also identified and remediable actions suggested. Next, please. Then WHO supported a large study was taken up on a very big systematic way in Haryana in 1718, and they also suggested the same thing. They published multiple angles from this study, and important observations were educating mothers and promoting home-based KMC for low birth weight babies reduces neonatal mortality by 30% and increases breastfeeding rates also and improves financial outcomes, and community supported KMC is effective, acceptable, and cost-effective intervention. Next, please. Then there was a few studies. Next slide, please. From Community Empowerment Lab, Shivgarh, UP. They also made efforts to promote community-based KMC, and their important observation was efforts for behavior change communication in the community helps to increase KMC uptake in the community, and all these are very helpful. Following that, there have been a number of studies which all have supported that community-based KMC is very useful, safe. Next. Now, and in year 2022, we found that WHO also has now recommended that KMC can be initiated at homes also. Of course, there were so many other things which Dr. Rajesh has already said. With this WHO recommendation, it had given a very big impact for promoting home-based kangaroo mother care in different countries and also in India. Next, please. So we have now tried to include home-based KMC in home-based newborn care. Only thing is, our request is it should not be trivialized. It should not be just a passing mention, but the worker should be given specific training for promoting home-based kangaroo mother care. It is not to be treated as an individual vertical program. We fully acknowledge that it is a part of essential newborn care, but till we properly achieve the good quality care by the health workers, their motivation, their compliance, conviction, and coverage, an independent component of training is required for home-based KMC. Only then they can appreciate the details and will be confident to incorporate it as a part of the home-based newborn care. Next, please. So we promoted a lot of home-based KMC training programs and modified from time to time according to the local needs. Next, please. In urban slums also, remote regions also, and different parts of the country, starting in the North India also, South India and many other places. Next slide, please. And training program was done for the different categories of community health workers in India. We have what is known as N.Vani workers who take care of the babies coming to the special childcare centers. Then also have home-based newborn care taken by our ASHA workers. That is our social health activists who are working as they are picked up from the local villages and trained for newborn care and other child health care. And they are now being given special training in KMC also, and they are helping us. Next. Now we have some suggestions for this. Next, please. When we want to introduce community-based care, certain alterations have to be made, as I have already suggested. So we have tried to produce modules. From time to time, we have even revised them and upscaled them or modified them according to the local needs and in different languages also. Next. And some of the practical suggestions we have tried to incorporate that. It's not possible to tell everything here, but at least one important thing in the community context I can mention is KMC can be initiated soon after birth for all the newborns, including term newborns and preterm low birth weight babies. Because in many of the community situations, it will be very difficult to identify low birth weight baby or preterm baby and then initiate KMC. Our experience showed no harm done in starting KMC, that is prolonged skin-to-skin contact for all the babies. If the baby is term, it is going to live within a few hours or 1 or 2 days. But even that few hours also will have benefit, especially in stabilizing the physiological status of the baby, promoting or initiating early breastfeeding, improving the mother's confidence in handling the baby, and so on. So, no harm done. So, all the babies can be started, but preterm and low birth weight babies should not be left out. So, that is the main problem. Training material to be produced as per the local culture and local needs. And then we use the analogy of a monkey. Our health workers have not seen a kangaroo. We have also, many of us have not seen a live kangaroo. So if we see the monkey, immediately we get the concept easily. Like that, I'm just putting some of the simple examples by which we have tried to convince our workers about the utility of Kangaroo Mother Care. Next. So this is one illustration which is very helpful for us in convincing our mothers and community health workers how to hold the babies and so on. Next. So in short, we have one significant perception that in deprived sections of society with no access to hospital care, KMC is many times life-saving. In middle-income groups, of course, it is cost-saving. And of course, quality improvement is there for all the babies. But this is just an emphasis. I'll just quickly give you 1 or 2 examples. Next. So this is a baby, 600-gram baby, due to several reasons. Though it was delivered hospitally, immediately it was discharged home. And then we found Our health workers convinced the mother and the grandmother to give KMC to these babies. Babies survived well. Today, the baby has a follow-up of 16 years, doing very well. Similarly, we have twins. These are all some of the early examples where we found these babies were largely benefited by Kangaroo Mother Care. Next, that also initiated us in presenting many cases. Next, I'll just give you some illustrations. So here is another home-based care in very rural, remote areas. And in these, we have got several other innovations also. When the mother is not able to hold the baby in KMC, nobody else is available. We have prepared a thermocol box also, which is according to the BMJ award-winning paper. And that also helps a lot of baby. Then how to prepare the place for the baby, how to prepare homemade reusable diapers, and so on. Next, please. Fathers are also able to give Kangaroo Mother Care. I'm talking in a remote rural villages where the culture is baby care is the function of only the women. But now the fathers and even grandfathers are able to help us in giving KMC. Next. Now the same baby which was given KMC less than 1 kg weight, now the baby is doing well. Follow-up shows. Next. Similarly, twins also, father, mother, both of them are participating. They are doing well. Next. Another set of twins. They are also being helped by the family members. They are doing well. Next. And you will notice these are all remote tribal areas, remote areas where due to several personal social reasons they could not go to hospital. Our health workers trained them for the Kangaroo Mother Care and these babies are surviving well. Next. Our health workers are now well trained. They are able to train the mothers also about the quality Kangaroo Mother Care and helping them for the breastfeeding. They have realized that Kangaroo Mother Care has got 3 important components. One is kangaroo position, that is holding the baby directly on mother's chest. And second one is providing as much as possible mother's milk in suitable mode. And third important component is ensuring proper follow-up for these babies. Next. So even in KMC transportation, I told you, now in the community, KMC transportation is very helpful. Initially, we started because there were no other alternatives, but subsequently we realized that is one of the best alternatives. Not only best alternatives, in some situations, there are papers saying that it is even better than the transport incubator transport. Next. And it has got several advantages, including zero separation of mother and baby and several other advantages. Next. That is another topic we are not able to tell you. But with all these backgrounds and efforts, and we have so far conducted more than almost 70 training programs all over the India. And now we find that states like Gujarat, Orissa, Maharashtra, Chhattisgarh, Rajasthan, Uttar Pradesh, Tamil Nadu, in all these places, KMC is being practiced in the communities, being introduced in communities, and lots of efforts are going to promote them. And even through the voluntary health service organizations who are working in difficult areas, Kangaroo Mother Care is gradually accepted very well. And now after this WHO study, we are now confident in promoting it even with much more vigor. And Tamil Nadu has now taken up 6 different districts for officially promoting community-based or home-based Kangaroo Mother Care, and other states are also following it up. Next. And there are several other examples by which we are able to do it. Having
Man,
now
can you please go yeah, faster, your time is us to
just
complete
2
this.
minutes now.
Yes.
I
Yes.
wanted to.
Thank you.
So we have now taken up an all India study also to find out what are all the difficulties in implementation of home-based KMC. And we did a national level workshop involving all the senior experts and the champions of KMC and also the community health workers and community agencies who are working in community for a long time with a long experience. And we have analyzed the difficulties at policy level, facility, community, family, and individual level. Next. Just we can quickly pass through the thing. So at policy level, what are the barriers we have realized? And the main thing is there is no proper system of linkages with the community health workers at the time of discharge from the family, and the component of training is minimal. Next. The same way we have tried to analyze at the facility level what are the problems. Next. Those who are interested, they can take these details later on. Community level also barriers, especially the local traditions and cultural beliefs, sometimes they hamper them from taking up this. Again, mind you, our first emphasis is to promote institutional care. But the situations where the institutional care is not possible or inadequate, in those situations, we are trying to promote community level KMC and newborn care in general. And community level KMC forms a part of community-based newborn care. Next. So likewise, we have studied at family level. Next. At individual level also. Next. And there are so multiple other factors. So my submission is just as the importance we give for the facility-based kangaroo mother care, equal or more attention is now required for giving care at the home-based KMC also, community-based KMC also, and all the government should make that special effort. Next. So, and there are so many action points we have suggested. Next. Yes, next. So individually you can analyze at your level and find out the possible solutions for improving the implementation. And next. So with all these things, now our putting way forward for the promotion of CKMC will be, it should be strengthened, particularly as a continuum of KMC at homes, following the planned discharges from the facility, and then training the workers, preparing suitable modules and training material in local languages suitable for their local culture, and promoting recording, repeating, and frequent analysis of their barriers and how to rectify the same. Thank you very much. Next, please. Thank you very much. My main submission is community-based care, KMC to be included in the community-based newborn care, and it is equally or even more important than even the facility-based care. Thank you very much.
Thank you, ma'am. Thank you for your presentation. The success and achievements of the community-based KMC in your setting is highly impressive and highly appreciated. It would inspire us to learn and apply that community practice, KMC practice in our settings as the situation allows. So dear colleagues, now we are approaching to the final agenda. So which is most critical section of the today webinar. So I wish you to continue to stay with us for a few more minutes to learn the most critical applications in informations that can be useful for your clinical setting. So before we proceed to the next presentation, we have prepared another short video clip with Myanmar subtitle. So please enjoy the video first. Yeah.
This is the story of how a mother's touch became a scientific breakthrough. In New Delhi, a team of medical experts are redefining a technique designed to save thousands of babies' lives. It's called
Immediate Kangaroo Mother Care.
Wait, did you just say kangaroo?
Inspired by kangaroo babies who live inside the mother's pouch, Immediate Kangaroo Mother Care, or IKMC, is essentially skin-to-skin contact between the mother and even the most unstable babies right from birth.
Meet Aarti Kumar. Her organization helps scale IKMC all across UP.
It's simple. Just keep the mama and baby together.
And this is her daughter Akshara. She's a bit of an expert on the subject. While IKMC is groundbreaking, it's based on KMC, a technique that's been around for decades but was only believed to be for stable babies. But a breakthrough discovery has shown its immediate effectiveness on unstable, preterm, and low birth weight babies.
We were not doing something right before.
Meet Dr. Behl. He's a global expert on maternal and child health research.
Normally, hospitals do not allow the mothers to be inside the room. A baby has to be separated from the mother and has to be cared for in an incubator.
But didn't she just say to
Keep the mama and baby together!
While working at the World Health Organization, Dr. Behl led the research with a team of medical experts, including principal investigator Dr. Chellani and his team at Safdarjung Hospital.
You have to generate the evidence through research. So we wanted to do a huge research project. Fortunately, the Gates Foundation partnered with us to go for this research.
Doctors tested IKMC on preterm babies by placing them on their mothers immediately after birth.
Finally, they had the results of this study and
Mortality was 25% less.
We found that up to 150,000 babies could be saved globally every year.
150,000! That's a baby every 3 minutes.
We have to reimagine hospitals to include the mother in the ICU so we can provide skin-to-skin contact along with all the other equipment.
And this gives more kids the opportunity to grow up to be whatever they want. What do you want to be?
Cricketer!
And you?
Cricketer!
Let me guess.
Cricketer!
Cricketer?
Doctor.
Really?
Yeah, of the cricket team.
This is going to be a paradigm shift. Now the World Health Organization has recommended in the new guidelines that KMC is to be given for all preterm and low birth weight babies. It's a result of a whole lot of people working together. It's a total teamwork.
Which makes the dream work.
It is immensely satisfying to think the research you have done would help save even a few lives, in this case, millions. For me, that is what keeps you going.
The Gates Foundation. Partners of human potential.
Keep them together. Just keep them together.
Dear colleagues, I hope you enjoyed the video. So it highlights the life-saving scientific breakthroughs of the immediate KMC. So now we are going for the last section. I would like to invite our colleagues, Dr. Chellani, to share about the KMC for the baby and special care units. So Dr. Chellani is currently such as a distinguished scientist at the Society for the Applied Study in New Delhi. With a career for spanning over 35 years, he has held pivotal positions across the various committees and task forces for the governments of India. So Dr. Chellani was trained at the Harvard School of Public Health in Boston for the improvement of the quality in health services. So he has also shared his expertise internationally as a consultant to the SAARC region, focusing on the scaling that's facility-based newborn care. So he has authored more than 100 research articles in chapters. For over 2 decades, he has been deeply involved in RCT research at both the community and facility levels. So notably, he served as a principal investigator for groundbreaking immediate Kangaroo Mother Care Action 3 trial. So please join me in welcoming Dr. Harish Chellani for the presentation. Sir, the floor is yours now.
Thank you, Situ, and thank you, Dr. Rajesh, Professor Shashi ma'am. In next 15-20 minutes, I'll be sharing with you the evidence which we have of the immediate Kangaroo Mother Care and, of course, the experience of this in our country. So let me share my slides. My slides are visible?
Yes, doctor, it is visible.
Okay. So, in this, I will be touching upon the new evidence on the kangaroo mother care, which came for the unstable babies. We just heard about the evidence of the community initiated KMC and about the guidelines which WHO brought from Dr. Rajesh. So, just to say that we have got the large of the low birth weight babies in the low middle income group countries, and most of the babies they die. If we see 80% of the babies die among these the neonatal deaths which happen among these babies. And it's not only the mortality, it is also the associated with this. Amongst the various causes which we have, a large proportion of the babies they die amongst the who are small and sick babies. And if we see these small vulnerable babies, which constitutes globally around 38% the premature and low birth weight babies, we have got the key 4 interventions: antenatal corticosteroid, initial and exclusive breastfeeding, feeding, the continuous positive air pressure, and of course the kangaroo mother care, for which we will be today talking about. So we heard in the beginning that KMC to be initiated at the facility, and it saves 40% of the mortality. It improves if it is started among these stable babies. But as Dr. Rajesh said, most of the deaths they happen before even the intervention these babies they receive, because for the stability to happen it takes few days. And as we know, half of the preterm babies they die within 24 hours and over 3/4 in the first week. And as you know, many those who are practicing newborn, it takes maybe few hours to 21 days before these babies they become stable. So that's why the hypothesis came, if I start KMC immediately at the birthing place, within 2 hours of the birth, does it improve the survival as compared to the conventional care? So this study was done in 5 countries: Asia, in India, and the 4 African countries. We took the population of 1 to 1.8 kg, because most of the babies who are below 1.8 kgs, they are cared in the newborn care units. So intervention group, they received the KMC soon after birth, and the control group received only once the baby becomes stable. So our intervention involved the KMC to be started within 2 hours, and we were aiming for 20 hours a day. Mind you, these are the sick babies, and even the babies who are with the respiratory support, they were cared onto the mom's chest. And because these babies are small babies, sick babies, unable to suckle, so the expression of the milk was done and these babies were fed. And because now you feel the KMC is to be provided more than 20 hours, so even the postnatal care, both to the baby and the mother, it was provided in the skin to skin contact care, right? So we included all preterms who are below 1.8 kg, twins, cesarean born, vaginal born, all babies were included in the trial. To make this operational, we started skin to skin care at birth, which is already the norm by the World Health Organization and the national guidelines. We provided KMC at the birthing place with the support of our obstetric colleague. And those babies who required the transport, they were transported in the KMC position either by the mother or by the surrogate, because many times obstetrician would like to watch these mothers for the postpartum hemorrhage. So we took only the low risk mother, eclampsia, severe anemia, or antepartum hemorrhage. Now these cases were shifted to the newborn care unit only after the mother gets stabilized. And we named the unit where, because you wanted mother and baby to be together, so the mother's bed in a way shifted from the postnatal ward into the NICU, which we call it mother newborn care unit. And once the baby becomes stable, the baby was shifted to the KMC ward or to the postnatal ward. So this you can see the picture. Baby is placed onto the mother's abdomen. Resuscitation done there, and once the baby is well and crying, those babies are then umbilical cord is cut after 1 minute and baby is shifted onto the mom's chest. Now in the central figure, you can see the transport of the baby is happened even with CPAP. So nowadays, you know, the CPAP is initiated inside the labor room. So these babies are shifted with monitor on, which you can see, and the mother is being shifted with the baby in the CPAP. Sometimes, as I said, mother is not available, then additional care provider or alternate care provider, or which we call as surrogate, shifts the baby to the mother newborn care unit. Now this is the picture of the Safdarjung unit, which was a 12-bedded unit which we started with. You can see the mother's bed, the radiant warmer, the nursing station, and this is a unit where mother and baby, they are cared 24/7. So if I can see the one cubicle of this, there is a warmer, there is a mother's bed, the baby in the KMC position, and there is a monitor. You must be thinking, if the baby is onto the mom's chest, what is the need of the radiant warmer? Yes, there are times when the mother is not available, or when the time when phototherapy is to be given, or the intravenous lines are to be put. Sometimes surrogate is not available and mother has to visit to the washroom or the bathing area. This is the only time when the radiant warmer will be utilized. These mothers are staying with the baby, so postnatal care for these mothers is provided by the nursing staff of the newborn care unit. So these nurses are trained to provide the postnatal care. You must be thinking this is an extra burden, but believe me that once the mother is inside, the mother takes the additional work of the nurses, which I will be covering upon. So these nurses are trained to provide the postnatal care, and naturally these these nursing colleagues, they are trained in midwifery. So instead of the postnatal care in the postnatal wards, these nurses are providing the care inside the nursery, right? And obstetric colleagues are taking the clinical rounds and providing the postnatal care inside the NICU, which we are labeling as mother newborn care unit. So this is what you can see is the couplet care, where the obstetrician and the pediatricians are taking the round in the same unit. So this is named as the couplet care. And since mom is staying, so within that complex, the mother's examination room, pantry, bathing area, and the washroom, they are also kept so that the mothers, they have the comfort and the facilities of day-to-day care. Now, if I tell you the results, we had a large sample size of 3,200, I will quickly go because of the shortage of the time. In the intervention group, you can see the KMC was started in the median time of 1.3 hours. Whereas in the control group, you can see you want to wait for the stability to happen. Only then you will be starting. So it took almost 2.5 days to start the KMC. And as I said, we included surgical cesarean cases as well as the twins also. When we found the duration of the skin to skin in the mother NICU or mother newborn care unit in the first 4 to 5 days, which you can see close to 17 hours, whereas it is in the control group, it was just 1.5 hours. But once the baby is stable, both these intervention and the control group babies are shifted to the postnatal ward. There you can see not much difference, 20 hours versus 19 hours in the control group. Now let's see the results as you saw in the video. We found 25% less mortality at 28 days of life, right? Which is a huge, and believe me, this is 25% additional to 40% which we get once the KMC is started amongst the stable babies. So this KMC, because we are starting amongst the unstable babies soon after birth. Similarly, the hypothermia incidences were less. And when we started this unit, I remember our mission director and everybody, there were a concern about the increased infection because the mother is carrying the, they thought, infection. But believe me, we got 18% less infection. And I will tell you the reasons for why we got this. Because the mother and baby are together, there is an effective and prolonged kangaroo mother care. There is an early and exclusive breast milk feeding. And believe me, the baby is onto the mom's chest. The bacteria which were there, healthy bacteria inside, the same bacteria are onto the mom's chest and which are less pathogenic than the NICU units. And there are opportunities once the mother is inside, she participates in the care of the baby, diaper changing, monitoring of the IV swelling, or even she tells you what is the oxygen saturation, whether it has crossed more than 94 or it has come below 90. And now we have quantified the stress also by looking at the salivary cortisol level. And we found these mothers and babies, we quantified salivary cortisol in both mother and the baby. And these steroids are much less in babies who are together. That means the cortisol level when it rises because there is a stress. And once cortisol level goes up, there is a poor weight gain. So once the baby and mom are together, there is a better weight gain and there is a less anxiety, and this is a developmentally supportive care. These results were published in New England Journal of Medicine, and immediately soon after that, this came as a full unit June 2022 in National Geographic magazine as Power of Touch. Now, there will be, in your mind, what are the major issues and concern? One, as I told you about the infection, right? The second is where will be the space? I think we should try to find out within the existing space if there is a space for the mother's bed, or when you are making the new units, right? Then mother's bed should be inside because now we have got the evidence. And obstetricians to take the postnatal care round inside. Believe me, this collaboration which one has to make it if you want to make the mother newborn care unit successful, start working together because the care has started from the labor room. So there is a big role of this collaboration, not only between the nursing colleagues and the pediatrician, but between the nursing colleagues, obstetrician and pediatrician. Uh, this you can see we did the post hoc analysis because we already found 18% less infection rate, and what we found, the bugs were different. Gram-negative organisms were more common in the conventional NICUs, whereas gram-positive were more with the mother newborn care unit. And sepsis-related mortality was 37% less in the mother newborn care unit. So I think big question comes, the immediate KMC, can it be used as an effective infection prevention tool? So this already Dr. Rajesh has already decided told to you, by this immediate KMC, the difference between the third row and the fourth row which you are finding, that means we are saving 150,000 babies additionally if I have to start the immediate KMC globally, right? So that's the advantage. Now looking at these all advantages, the World Health Organization recommended these guidelines, which you already know, but the minimum duration which was not there. In fact, in our portal, the reporting portal, it is yes or no. But now the quality indicator which has been added, that is the duration and minimum 8 hours. I would say the places where the mother newborn care unit is not there, at least mother should be allowed as much time as possible. I think that policy change must be done so that the mother can provide care 8 hours in 24 hours. Okay, change in the SNCU, in our NICU, if you want the WHO guidelines to be imposed, if you feel then obstetric and collaboration has to be there, and it is important for us to allow the mother and surrogate in the newborn care unit 24/7. I think that policy change needs to be done. Then, if I see the experience based on the WHO guidelines which came, the government of India also released its guideline on 17th of the November 2025 on the prematurity day, and also the CPAP as well as the KMC guidelines, they were released in the operational guidelines. KMC to be practiced at each district level facility, right? And stable babies at FRU level. So in our operational guidelines, we have kept as per the international norms, because World Health Organization had set the norms for the mother newborn care unit. And now if you want to have one unit like this, 250 square feet is required, and 220 square feet is required when you are having a bed without CPAP, and 270 with CPAP. So if you keep a mid figure of 250, you can have in a 12-bedded unit 4 beds of the CPAP, because roughly it is 25 to 30% of our admission in the level 2 care unit or of the respiratory involvement. Similarly, the government of India has made some of the architectural design where you have these units, 12-bedded units. So what I would suggest, that if there is some space constraint, don't compromise on to the mother baby diet area, but the washroom bathing area, even if it is not in the same complex, but in the adjacent complex. But of course, it should be very close to the unit that can be decided. And you can see the previous guidelines. Now the budget for this mother newborn care unit has been increased. Previously, of course, it was less amount, but now the revised 2025 guidelines, the budget has been incorporated in the project implementation plan. We have also kept the additional budget for the KMC chair and the KMC governments. Even the manpower, previously you can see there was one nurse for the 4 beds. Now you are having one nurse for 3 beds. So that's how the nurse bed ratio has also been improved in the revised guidelines. So friends, I would say seeing the benefits of the mother newborn care unit, and though I'm taking the session on KMC, but KMC cannot be taken in isolation. It is just one intervention. A package of intervention has to move together where the CPAP, antibiotic use, management of hypothermia, all these have to be integrated, care at birth. And if the mom and the baby are together, believe me, sometimes the issues of the human resource, the nursing staff especially, lot of work has been taken care by the our mothers. In fact, we have quantified 60% of the work of the nurses can be done by the the mothers, and the nurses can focus more on the intensive care. It requires a teamwork, it requires the capacity building so that they learn the art of the kangaroo mother care among the sick babies, and also how the CPAP, the expression of the breast milk, all these can be provided in the KMC position. So in the end, friends, I would say that involve the mothers as a care provider rather than only a visitor. And we, the healthcare provider, have separated our babies from mother in the past. Of course, with best evidence which was available to us at that time. But now we should start practicing zero separation, understanding the physiology, and of course, we would be safe because these have been the World Health Organization guidelines, and more so, it will be incorporated in the national guidelines. So thank you very much. I will stop here, and if there are any questions, I'll be too happy to take it. Thank you very much.
Thank you, sir. Thank you. So we are so grateful to learn about your experience on the MNCU and how it is ensured to save the many life of our newborn babies. So now we will proceed to the Q&A, although we are running out of time. So I would like to invite our 3 speakers appear on the screen. So we have a number of questions on the Q&A box, which was kindly addressed by our speaker as relevant. So I would like to pick 3 questions only, one for each of you, which is most important to know by the audience. The first question, which is for Dr. Chellani, it's can I know how to practice a KMC and small baby with absolute contraindication to breastfeeding? So as mother can mistakenly offer the breastfeeding while in KMC. So it's practice practice in KMC with absolute contraindication to breastfeeding. So which is for you, sir?
So see, the contraindication to breast milk feeding are exactly the same as we have otherwise. Those mothers who are psychotic mothers or those who are on antipsychotic drugs. So in fact, these are only the absolute contraindication, but rest of the there is no contraindication, and if she is taking antipsychotic drugs, but otherwise even in all conditions, she can express the milk and milk can be fed to these babies. So I won't consider any contraindication to breastfeeding in the KMC position. Even those babies who are critically sick, right? Once they are stable and you are allowing the oral feeds, because nowadays, except the babies who are on shock or critically sick on vasopressor, we can give minimal enteral nutrition on from day one. So we can start 20 to 30 ml of breast milk to be divided in 4 to 6 feeds in 24 hours. So I won't consider any contraindication except the baby who are on vasopressors for that period only.
Thank you, sir. Thank you, sir. It is very clear. So it is short and we were noting it on this. So let me pick another question, which is for our man, Prof. Shashi. So what are the cultural beliefs in practice in deter it is kind of the resistance for the application of KMC in the culture like India in Myanmar? So how do the community health workers overcome this barrier? The resistance from the community on KMC, man. Over to you. Yes.
See, generally, if you have not educated or counseled the family members, they believe that the mother and the baby have to be kept isolated for the first 40 days. It varies from place to place. But one of the commonest condition is to keep the mother and baby isolated, separated. And another thing is not to initiate breastfeeding till certain rituals have started. Another feeling is keep the baby and mother in a dark room, give them only certain rags to use and so on. Like that, these are all some of the cultural things which hamper kangaroo mother care, because all the time, and again they believe that all the time mother cannot hold the baby to her chest. It is not safe. And all these prevent them from giving kangaroo mother care. And other family members many times do not help in taking care of these babies, except for one or two old women in the family. And men folk are not allowed to take part in the child care at all. This happens in many of the cultural things. Of course, now with the education and more involvement of health workers, gradually these are changing. And another important thing is many times the tribal women, they have to start work immediately after that. They do not have time to spend with the baby. So in different cultures, there are different variations, and we have to have a lot of time in talking to them, counseling them, and bringing about a lot of behavioral change. So that is very important.
Thank you, man. Thank you, man. Points are very important. We are very helpful with this information for our colleagues also. Yeah. So let me pick one last question, which is for our colleagues, Dr. Rajesh. What are the benefit of KMC compared to the incubator? So over to you. Yes.
Thank you. I think Sidhu, I have already answered, but most importantly, all the studies that have been done, the evidence that has been generated is compared to the conventional care, and incubator care is one of them. But specifically, if you look into incubator, there is a increased risk of infections, hypothermia when the child is in incubator care. So morbidity, and also that increases the risk of mortality when you compare it with KMC. Another important challenge is that the breastfeeding practice. Initiation of breastfeeding, continuing it for breastfeeding when the child is kept on the mother's breast, chest, it definitely leads to increased oxytocin release and the release of breast milk and the maternal baby bonding. So these are some very important things which are not possible through incubator. And lastly, incubator is a expensive option. It's costly. It requires maintenance, electricity. So that's probably, I would say, the least important. More important, I would say, is the benefits that you have in terms of reduction of mortality, morbidity, and the bonding that is required.
Thank you,
Can
sir.
I
Yes, please, sir.
Dr. Setu, just to, one additional thing which we found in our trial, the disadvantage of the radiant warmer. We all talk about hypothermia, but many babies, they become hyperthermic in the radiant warmer when the probe gets displaced. And the many babies, they develop hypernatremia and hyperthermia because of the hyperthermia, and that with mother's chest, no baby will go into hyperthermia unless the mother is having high temperature, which is generally not the case. So I think beside the advantages which Dr. Rajesh has mentioned, these are the physiological things. I mean, and the never ever the machine related complications which they happen. The infection rate, as we found and which we published in Lancet also, the gram-negative bugs are very difficult to treat. No matter how much cleaning or asepsis you maintain, that infections will be there in the hospitals.
Yes.
And one
Yes.
Yeah. Another important thing is the mother and baby, both of them have an emotionally supportive care. And it helps the mother also in reducing her stress and her thing. That is never happen with when you keep the baby in the incubator. So this is a very important thing. It's a loving hug, not just mere skin to skin contact, superficial. Yeah. A lot of emotions are upsurge, a lot of hormones are improving. Oxytocin is one, but there are several others which all help in early initiation of breastfeeding, early bonding and all that. Baby benefits definitely, but mothers also benefit and the families also benefit, which can never be had if you separate the baby and mother, keep it in the incubator. So that important component we can never forget.
So thank you, doctors. The points are so thoughtful and very practical. So thank you. So we are already running out of time. So I would like to conclude the Q&A session here. So now we are at the closing part of the webinar. So I believe the valuable information we share by today will greatly enhance and helpful our knowledge on the in practice on the KMC. So we would like to express our sincere thanks again to our honorable speakers, Dr. Rajesh, Khanna, Dr. Harish, Chellani, and Professor Shashi N.Vani for your dedication on this critical area and for sharing your expertise with us today. So we are also sending thanks to our colleagues from RMNCA's team of WHO country of Myanmar for organizing this wonderful event. We are also thanks to our excellent Myanmar language interpreters during the events. So WHO country office will continue organizing a series of online technical webinars during the 2026 in monthly visit to share the WHO recommendation on the reproductive, maternal, child, and newborn and child health area. The speakers and resource person of all the webinar will be our technical expert from the WHO headquarters regional office and partner organization who were very much involved in leading the developments and implementation of these recommendations. So meaning that you will be having the very first-hand knowledge and updated from the experts. So please stay tuned. We will share the invitation and publish in advance. So we cordially invite you to join the coming webinars. So last but not the least, we would like to request all the attendees to respond to the evaluation and feedback forms of the webinar. The feedback form will appear on the screen, your screen, once you leave the webinar. So please kindly provide your your input and feedback so that we can make it better in the coming webinar. So with these informations, and great thanks to the attendees and speakers. So please allow that to conclude our webinar. So thank you and see you again in the next webinar.
Thank
Thank
you very
you.
much.
Thank you.
Thank